Good afternoon, my name is Amiee and I'm an Acting Staff Development Nurse in ICU at Sir Charles Gairdner Hospital. Today I will be speaking to you about the nursing management of the liver transplant patient in ICU. So far this year, 10 liver transplants have been performed. One of these liver transplants was already an inpatient in ICU with fulminant hepatic failure. This photo is of that fulminant hepatic failure patient and is typical of how an unstable post-operative liver transplant patient presents. My objective today is to describe to you his ICU admission. I will be coming back to him a little later. When our patients return from theatre post-transplant, they are admitted into a single room and nursed one-to-one. The first hour is busy, with medical staff and at least 2, if not 3, senior nursing staff working solidly to ensure that these patients are ventilated appropriately, monitored, all necessary infusions are running, they are warmed adequately, and they receive a chest x-ray, bloods, ECG, and observed until they stabilise. However, if they are unstable on admission, be that from surgical complications such as bleeding or simply the complexity of the patient, the first few hours may involve transporting an unstable ventilated patient out of ICU and down to CT scan, or possibly back to theatre. From these such complications, discharge can be delayed from days to weeks. If they are stable, discharge from ICU can be within 24 to 48 hours, where they will be specialed on the ward. This graph demonstrates indications for liver transplantation, showing chronic versus acute liver disease. Management of the transplant patient can be generally divided into these two limbs. Firstly, there are the stable, more routine transplant patients who are suffering from a chronic illness such as alcoholic cirrhosis or hepatitis, seen above as the 2 most common contributing factors to liver transplantation. These patients are relatively stable. They are on the transplant list and awaiting transplantation on the wards, where their care can be monitored and optimised. Then there are the acute liver failure patients. These are very sick and critically ill patients suffering from acute fulminant hepatic failure, commonly induced by either medication toxicity, a metabolic disturbance, or of idiopathic origin. They are sick and are given the highest priority in almost all allocation systems. If they do not receive transplantation immediately, then they will die. So I will be using a systems approach to discuss the nursing management and highlighting the difference between our routine stable patients and our critically ill unstable patients. Neurologically, our stable patients will return in an induced coma where we keep them sedated overnight or until they stabilise. Propofol is usually our agent of choice as it is short-acting. Benzodiazepines and opioid use is usually restricted as much as possible, as it not only delays the waking process, but is more difficult for the new liver to metabolise and excrete. Adequate analgesia is important post-operatively to ensure the comfort of our patients and allow them to progress to mobilisation and deep breathing post-operatively. As our patients are sedated and ventilated overnight, our only form of neurological assessment is papillary changes, which are monitored hourly. Nursing staff are constantly monitoring for any neurological abnormalities, and patients are scanned if indicated. Neurologically, our more complex patients will require more time before they can be woken from their induced coma. Although not proven, high ammonia levels are thought to lead to cerebral edema and severe encephalopathy, which will require time to resolve as these newly transplanted patients clear out those toxins. This, with the added risk of coagulopathy and intracranial bleeding, requires very close neurological monitoring. If CT scan demonstrates a tight brain, then intracranial pressure monitoring may be required for ongoing management. When these patients are stable enough to wake, they often do so badly. Waking in a loud, bright, unknown and foreign environment can be very distressing. That, accompanied with resolving encephalopathy, can make for a very confused, agitated patient. They often require medical orders for physical or chemical restraints to ensure that they do not harm themselves or nursing staff. This can be very distressing to patients' family who will require constant reassurance and support. Respiratory management of a patient involves overnight ventilation, patient positioning, close arterial blood gas monitoring, chest physio and secretion clearance to ensure that respiratory function is optimised. Once the patient is weaned down to minimal ventilation support and all teams are happy, then the nursing staff will go ahead and extubate. Physiotherapists work together with our nursing staff to encourage early gentle mobilisation and deep breathing to reduce their risk of respiratory complications. Non-invasive ventilation or high-flow oxygen therapy may be needed post-extubation, but is usually weaned off quickly. Respiratory complications will often be the largest factor prolonging their ICU stay. Intraoperative complications such as tension pneumothorax and pulmonary embolism can occur and must be managed immediately and on return to ICU. Most patients have a pre-existing lung pathology such as pneumonia, pleural effusions, pulmonary hypertension, or an obstructive airway disease. This can require complex modes of ventilation pre- and post-transplant. Long-term sedation and ventilation comes with an increased risk of ventilator-acquired pneumonia, acute respiratory distress syndrome, and increased muscle wastage, making it more difficult to wean these decompensated lungs from dependence on positive pressure ventilation. If extubation after 10 days is not looking likely, then we will need to consider tracheostomy to enable these patients to wean respiratory-wise. Patients will return to ICU with ECG monitoring, continuous arterial and central venous pressure monitoring that will be closely watched by nursing staff to observe for hemodynamic stability. Pulmonary artery or PA catheters are used intraoperatively and on return to ICU for patients who pose potential hemodynamic difficulties. PA catheters are an invasive but accurate diagnostic tool that provide advanced clinical information on the patient's hemodynamic profile. This directs their management towards either increasing fluid or inotropic support in order to manipulate their cardiac output. Patients are then warmed to normothermia and able to wake once hemodynamically stable. Patients will also receive a full blood screen on return to ICU and then twice daily once stabilised. Hemodynamic instability post-transplant can be due to a range of underlying conditions. Acute liver failure can cause arteriovenous shunting, increased cardiac output, and an abnormal blood volume distribution. This, together with abnormal sympathetic and hormonal vasoconstriction, possible left ventricular dysfunction, and low albumin causing third spacing, make for a very unstable patient. Pulmonary artery pressure monitoring is used to perform frequent cardiac outputs by the bedside nurse to direct their therapy and improve hemodynamic instability. These devices require advanced ICU skills, and therefore management of the post-operative liver transplant patient can only be cared for by senior nursing staff. Coagulopathy, which can result in bleeding, is constantly monitored post-operatively. Deranged ionars, APTT, platelets, hemoglobin are corrected and blood products are given as they're required. Hypothermia post-operatively can exacerbate their coagulopathy and is monitored by nursing staff who will actively warn the patient until they're normothermic. Unstable patients may be septic as well, which again contributes to their hemodynamic instability, their coagulopathy, and their multi-organ failure. Routine hepatic management involves twice daily and PRN liver function testing to ensure their ALT, bilirubin, GGT, as well as their lactate are not deranged. Constant observation is needed by nursing staff to monitor for evidence of any complications. An ultrasound in ICU on day 1 is performed to ensure no obstructions are seen and that the liver's circulation and biliary system are okay. All abdominal drain output is monitored hourly to ensure adequate bile production and that bleeding is controlled. SPAT, or single-pass albumin dialysis, can be used as an artificial extracorporeal liver support that assists the failing liver to clear protein-bound toxins and waste, acting as a bridge to transplant. It is not usually required post-operatively. Once these patients receive their liver transplant, management of complications such as bleeding, hepatic artery thrombosis, sepsis, and primary non-function may require transfer back to CT or perhaps back to theatre. Close hourly monitoring of every body system is needed by ICU nursing staff to ensure that the newly transplanted liver is cared for and complications are minimised. Renal management of our routine patients involves strict fluid balance, which is documented hourly by nursing staff with a running total 6 hourly to ensure that adequate balance is maintained. Urea, creatinine and electrolyte monitoring is frequently checked and supplemented by ICU nursing staff to reduce their risk of cardiac arrhythmia. Post-operatively, patients are in danger of developing acute renal failure as pre-existing renal impairment, prolonged hypotension, high transfusion volumes all greatly increase their risk, so must be monitored very closely. Although rare, some liver failure patients may be suffering from hepatorenal failure prior to liver transplantation, requiring pre- and post-transplant dialysis. ICU nurses monitor and manage their continuous renal replacement therapy, which is often labour-intensive and very time-consuming. Critically ill, septic and hypotensive patients can develop acute tubular necrosis, putting them into acute renal failure, ultimately requiring renal replacement therapy. Stable, routine patients will have early feeding regimes, usually being enterally fed to ensure nutritional requirements are met. 4-hourly aspirates are monitored by nursing staff to ensure that all of their feeds are being absorbed, and patients are nursed with their head elevated to 30 degrees to reduce their risk of aspiration, as well as administration of antiemetics to reduce their risk of vomiting and increase their gut motility. Bowel care is closely monitored by nursing staff, as well as tight blood sugar control. Unstable patients who have been acutely unwell prior to the liver transplantation may not have been tolerating their diet and could be at risk of refeeding syndrome, as well as malnourishment. As gut motility in the critically ill slows, patients may be at risk of ileus and will not be able to tolerate enteral feeding. These patients are also at risk of translocation of bacteria from the gut, which can be another contributing source of sepsis. Abdominal CT may be required to confirm ileus or an obstruction, and TPN may need to be initiated. Control of blood sugar levels is also required until the transplanted liver is functioning. To ensure that our stable and our critically ill patients maintain good skin integrity, general nursing care is of great importance. As critically ill patients in induced comas have poor skin integrity and reduced circulation, they are at greater risk of skin breakdown and deep vein thrombosis. To reduce this risk, all ICU patients are nursed on a Nimbus mattress, turned by nursing staff and orderlies every 2 hours, and wear TED stockings and Flowtron calf pumps. Sedated ventilated patients require a full wash using MicroShield soap and full linen change at least daily, usually overnight. 2-hourly mouth care and eye care can protect the sedated patient from ventilator-acquired pneumonia and corneal abrasions. Psychosocial care is a large part of ICU nursing management for liver transplant patients. Patient and family anxiety can range from individual circumstances to miscommunication to a deficit in knowledge surrounding their patient care. Leaving ICU can also create anxiety for the patient, particularly for those who have had an extended stay, as they become accustomed to this one-on-one nursing care and feel apprehensive without it. Patients also struggle with either feelings of extreme happiness or guilt and sadness when they receive a transplanted liver. This can be overwhelming and require support and reassurance from nursing staff. Nursing staff work together with the multidisciplinary team to combat and minimise these issues. Collaboration between medical, nursing, physiotherapy, occupational therapy, pharmacy, social work and welfare facilitate good support networks, education and compliance. This photo is of an ICU patient recently admitted for fulminant hepatic failure from medication toxicity. This is a more atypical rather than routine transplant patient. He was not placed on the transplant list until his admission to ICU, where he was given the highest priority, going to the top of the list. This is a typical ICU bed space, and you cannot see his face, but he is sedated, ventilated. He's on multiple infusions, including inotropic support for his blood pressure. He's being enterally fed, which is hidden over here, and he's on dialysis as well. He's critically unwell with multiple infusions, and if he did not receive his liver transplant urgently, he would have died. This photo is immediately post his transplant. He received his liver transplant within 48 hours of admission and has now been moved into a side room for isolation. He is still sedated and ventilated. He still, again, has multiple infusions running and now multiple drugs for inotropic support. He has a PA catheter here and he's still on dialysis and being enterally fed. He requires hourly neurological, cardiovascular, respiratory, renal and GI2 observation, 2 hourly turns, twice daily chest physio, suctioning, arterial blood gases, twice daily full blood screening, 4 hourly aspirates, close blood sugar monitoring, bowel care, 2 hourly mouth care and eye care plus more. He is a busy, complex and critically ill patient. This is taken 1 week post his transplant in his last few days of ICU. The photos appear similar, however demonstrate the slow respiratory weaning process that's required to rebuild all of his muscle and lung strength in order for him to breathe spontaneously. As he was encephalopathic following his transplant, he required longer time to wake, and so he was unable to avoid a tracheostomy insertion for longer weaning time. So the picture on the left shows that the ventilator is on standby, and now he has oxygen therapy connected to his trachea. And the picture on the other side shows that the ventilator is now reconnected, as he's only able to tolerate short trials of the ventilator. This is not a quick process, as he's still very weak and decompensated with muscle atrophy. However, he has greatly improved after only a week. The majority of his infusions are now down. He's only got enteral feeds and maintenance running. He's able to support his own blood pressure without inotropic support, and he's able to control his own blood sugar levels without insulin therapy. He's also off dialysis. On discharge, our patients are left with minimal lines and drains. They should be self-ventilating and able to sit out of bed. Some will require further specialling on the wards. It can be a short or a long journey through ICU intensive care. However, discharging your patient from ICU with a new liver is what makes intensive care nursing so rewarding. Thank you.